Hello, welcome back to the channel. Today we are going to discuss a commonly seen dental anomaly, hypodontia or missing teeth. Hypodontia refers to developmental or congenital absence of one or more teeth. According to Schaeffer's textbook of oral pathology, hypodontia is the absence of one or more teeth in the primary or permanent dentition, most commonly affecting permanent teeth. Importantly, third molars are excluded. On the other hand, Neville's oral and maxillofacial pathology defines hypodontia more specifically as the congenital absence of 1 to 6 teeth, also excluding third molars. Neville highlights that most commonly missing teeth are maxillary lateral incisors and second premolars. Hypodontia is the most common developmental dental anomalies in humans and may affect either the deciduous or permanent dentition. Primary tooth hypodontia is less than 1% in incidence. It often predicts permanent tooth agenesis due to dental lamina defects affecting eruption and occlusion. On the other hand, permanent hypodontia affects 3.5 to 6.5 globally and 4 to 8% in Indian population. It's more common in females. Hypodontia refers to the congenital absence of 1 to 6 permanent teeth. When more than 6 are missing, it is called oligodontia, and when all teeth are missing, we call it anodontia. Sometimes you will hear the term partial anodontia, which simply means hypodontia. Now, based on the cause, missing teeth can be true anodontia or pseudo anodontia and false anodontia as well. True anodontia where the teeth never developed. In case of pseudo anodontia, the teeth are present but haven't erupted. And false anodontia is where the teeth were present but lost due to extraction, trauma, or disease. Finally, the hypodontia may occur with syndromes like ectodermal dysplasia. This is called syndromic hypodontia. If it happens in isolation without any other systemic issue, we call it non-syndromic. Now, coming to the etiology of hypodontia, first of all, we'll discuss the genetic factors which are responsible for hypodontia. As hypodontia has strong genetic basis, it often runs in families with mutations in the gene like MX1, PAX9, AXIN2 and EDA being common culprits. The inheritance may be autosomal dominant, recessive or X-linked. Hypodontia may occur as a part of syndromes, as we have already discussed, or non-syndromic conditions without any other health issues. Second etiology is the environmental factors. They can disturb the tooth development phases. Maternal infections like rubella or toxoplasmosis, exposure to radiations or trauma during early development may all lead to hypodontia. Certain drugs like thalidomide or chemotherapeutic agents are also implicated. Nutritional deficiency, especially in vitamin A and D, and factors like premature birth or maternal smoking during pregnancy can also play an important role in hypodontia. Third etiology may be the epigenetic and the local factors. Epigenetics means the gene expression changes caused by the environment, and these can impact tooth development too. Local trauma such as injury to primary teeth or developing tooth germ may prevent permanent teeth from forming. Other local factors include the space issues in the arch, pressure from cyst or tumor, or irradiation, which can disrupt dental development locally. Hypodontia causes are broadly classified into general and local categories. The general causes include genetic and syndromic origins like ectodermal dysplasia. Local causes involve trauma, infection, or cyst affecting the specific area. It may also be syndromic, associated with the conditions like cleft lip or Down syndrome, or non-syndromic where the tooth absence is isolated without other abnormalities. Dominant is the most common type of inheritance in hypodontia. A person only needs one copy of faulty gene from either parents to be affected. If one parent has hypodontia, there is 50% chances the child will too present with hypodontia. Autosomal recessive inheritance in hypodontia is less common. The person must inherit two copies of faulty gene, one from each parent. If both parents carry the gene, there is 25% chances that child will be affected. The last mode of inheritance is the X-linked inheritance, where the gene responsible is on X chromosome. Since males have only one X chromosomes, they are more likely to be affected and often more severely affected. Females have two X chromosomes, so healthy one can compensate. Now coming to the diagnostic part of hypodontia. Diagnosis hypodontia begins with clinical signs such as delayed tooth eruption and gaps in the dentition. A thorough intraoral examination involves tooth counting, symmetric check, and identifying retained primary teeth without successors. Radiographic confirmation using OPG helps differentiate between congenitally missing teeth and those that are unerupted or impacted. Absence of tooth bud confirms true hypodontia. Family history is also important, as hypodontia often follows an autosomal dominant pattern. Clinician must also assess for systemic signs suggestive of syndromic involvement, such as skin, hair, nail, or sweat gland abnormalities, which are present in ectodermal dysplasia. If only teeth are affected, the case is classified as isolated hypodontia. If accompanied by other features, it is syndromic. Now, talking about the clinical implications of hypodontia, then it can have wide ranging implications beyond just missing teeth. Aesthetically, it significantly affects facial appearance, especially when anterior teeth are involved. Functionally, it can impair speech, mastication, and lead to occlusal disturbances. Psychologically, the condition may cause anxiety, low self esteem, or even depression, particularly in young patients. Orthodontically, hypodontia complicates treatment planning, leading to space management issues, malalignment of teeth, or difficulties in bracket placement. From a restorative point of view, options may be limited based on available space and remaining teeth. Lastly, the financial burden can be considerable due to need for long-term interdisciplinary care. Even a single missing tooth can disturb the balance of the entire mouth. The neighboring teeth tend to shift or tilt into empty space, while the opposing tooth from the opposite side may over erupt due to lack of contact. These changes can lead to bite problems, jaw discomfort, and uneven wear on other teeth. Malalignment also makes cleaning more difficult, increasing the risk of cavities, gum diseases. Cases where the hypodontia is mild, the skeletal pattern looks absolutely normal. But in severe cases, especially when many teeth are missing, as in case of oligodontia or some other conditions like hypohydrotic or ectodermal dysplasia are present, then there may be the changes in facial structures. This may include a concave facial profile where the face appears flat or sunken, a wider nasolabial angle, retrognathic maxilla, a shorter facial height in front, a flat or lower jaw angle, or overall the vertical height of the face is reduced. These all changes can affect both appearance and bite and may influence how the treatment is planned. When a patient has hypodontia, treatment depends on how many teeth are missing and the impact on function and appearance. In mild cases where one or teeth are missing, if there is no major problem, sometimes no treatment is needed. If spaces affect smile or bite, the dentist may close the space using braces or keep the space using space maintainers and may plan for future prosthetic replacement. In case of moderate to severe cases where the multiple teeth are missing, they require a team approach. Orthodontist, pediatric dentist, prosthodontist, and sometimes a surgeon for implant in future. They check age, jaw growth, and facial profile to decide the best timing. During growth between the or before the 16 to 18 years of age, the implants cannot be placed yet, so they maintain the space or use temporary replacement like dentures, adhesive bridges, or resin buildups. After the growth is completed, post 16 to 18 years of age, now the final options can be planned for the patient of hypodontia, which may include the dental implants, which is most long lasting and natural, bridges, fixed tooth supported options are there, and dentures, removable one, are used if many teeth are missing. Composite or veneers may also be an option of treatment if reshaping is needed for small or peglateral teeth. This is the way the treatment is personalized depending on the age, aesthetics, and the bite. So in nutshell, we have to decide in case of hypodontia whether we have to close the space or fill it. Space closure means using orthodontic treatment like braces to move nearby teeth into the gaps, which can be ideal if it improves the bite and appearance. So on the other hand, space filling means keeping the gap for future replacements such as denture, bridge, or implant, especially when closing the space may affect facial balance or function. The choice depends upon the number of the missing teeth, patient age, and overall dental health. Thank you for watching. If you found this video helpful, give it a thumbs up and don't forget to subscribe for more dental education made simple. Drop your questions or experiences with hypodontia in the comment box below. I would love to hear them. See you in the next video. Till then, bye bye. Take care. Have a nice day.